So, this is where the stuff is in your book. So these are kind of what we're going to talk about. You know, 80 to 90% of births, even pre-hospital, are totally normal and everything goes perfectly well. There are the cases where things get a little wonky. There's a couple of abnormal deliveries we'll talk about. We'll talk about pre-delivery emergencies, so some of the conditions that happen that cause women to need to be in the hospital to deliver babies. Up here right now we have a midwife out of Merrill that covers this area, and she does have clients up this way. So the chance is not zero that you won't run into somebody going into labor and she isn't here yet. And that can have effects of them calling 911 because there's nobody there and baby's coming quickly. So it's not a 0% chance that this is going to happen, but it's not a huge percent chance either. So the first thing we'll talk about is they do a case study.
We've never looked at the case study.
Yeah, women have babies all over the world without any assistance from anybody. They have babies in potato fields, they have babies on the side of the road, they have babies in their house, they have babies in the hospital. It's a totally normal process, though EMS has always made childbirth feel like an emergency because we're uncomfortable with it. It feels uncomfy. It's like having a sick kid. You just kind of feel uncomfy about it, right? It's not an emergency 90% of the time. There are complications that happen, but again, those are the things we'll talk about. We'll kind of teach you how to handle what you are able to handle. There are people that have babies at home without any assistance at all. Not highly recommended, in my opinion, but it happens. So the anatomy of a pregnant woman, your ovaries carry your egg, which is what you need to make a baby. Egg and sperm come together. You guys should have all learned that a long time ago, most of you. Babies grow in the uterus. If a baby starts to grow in a place other than the uterus, that's bad news. I think it'll show a picture here shortly. There is the uterus. The placenta is what essentially feeds your baby. It attaches to the wall of the uterus, connects to the baby via an umbilical cord. That thing will come out after the baby's born. Again, your umbilical cord connects and provides the nutrients to the baby. There is two veins and an artery in an umbilical cord. The amniotic sac is that fluid that the baby's like hanging out in, floating around in. Your water can break prior to you going into labor, your water can break in the middle of labor, your water can break right before the baby comes, or they can be born what's called en-caul, which means that they are born inside that bag of water. It's actually super, super cool. Looks really weird. They're like floating around in this bag of water. It can contain up to 1,000 mLs of fluid. So like what you think, that's like a whole liter. So like a liter of soda, that's how much fluid it can have in there. You can have a partial rupture of membranes, which is what they call it. So like their water breaks a little bit, but it's not completely ruptured, or the baby reseals it with their head and there's still fluid back behind it. So, hi. So the vagina is the lower portion of the birth canal. So you have the uterus, the cervix is like the connecting piece, and then the vagina. There. That's what it looks like. Ta-da. If you have any questions. I'm sure there's a picture in your book. I don't think we need to talk about the menstrual cycle, but you can read about it in your book if you'd like. So pregnancy technically lasts 280 days, so it's 9 full months. It's not 8 months and 30 days, and when you get to 8 months and 31 days, it's now baby's coming. Due dates are an estimate. They think they're close to guessing when babies are supposed to come, but they really are not very good at it. It's a 2 weeks from on either side of when they tell you that you're due is your actual, like you have a due month, essentially. There is 37 weeks is considered early term, 38 weeks is term. Some OBs will let you go up to 41 or 42 weeks. It depends on how you're doing, how baby's doing. There's a lot of physiological changes. Obviously, there's changes in the body. Your ligaments and joints become pretty lax. So as women get further in their pregnancies, they'll have pain in their pelvis because everything kind of loosens up getting ready for childbirth. All your organs get displaced because there's, now a growing human in there. So their stomach gets pushed up, their lungs feel like they can't expand all the way because there's, something pushing on them. Their bladder, let me tell you. The uterus is really small in someone who's not pregnant, and it grows to hold a whole human being. So that's a pretty amazing thing all by itself. Your blood volume increases as well when you're pregnant. So this is just talking about like the respiratory, your tidal volume increases because everything's pushed up, but it's kind of hard to explain. Like things are pushed up and out of the way a little, but you still are having to breathe harder because, you're carrying a baby and you're doing all those fun things. Your respiratory rate a lot of times will increase. Your cardiovascular system, so your output increases, your blood volume increases. A lot of times their heart rate gets a little faster. Usually in the beginning, their blood pressure will be a little bit lower, the first and second trimesters, but at the third trimester, it typically returns to normal with no complications. Your GI system, so a lot of people get sick in the first trimester. Some people get sick all the way through. Constipation happens, sometimes bloating happens, sometimes because there's things pushing on your organs. Heartburn, so they say it's because of the progesterone, but I think it's because that baby's shoving your stomach up into your diaphragm. You pee more because your bladder's a little displaced from the uterus. I've talked about the pelvic joints getting kind of loose. Your tendons and stuff get looser so that your body can push out a baby. Your center of gravity changes too. Like if you think about strapping a bowling ball to the front of your body, your body changes a little the way that it stands up. So we'll talk about some pre-delivery emergencies. Antepartum is what it's called, hyperemesis gravidarum. So this is more than just first trimester motion sickness. First trimester morning sickness. This is I throw up every day, multiple times a day, every day, past my first trimester. This is usually when people end up in the hospital, frequent IV rehydration. They're on meds for vomiting. They're on Zofran consistently. There's a med called diclegis, which is supposed to be pregnancy safe for nausea and vomiting. It's pretty bad. You can be hospitalized. This can cause your body essentially goes into failure. You don't have any nutrients to feed your body. Your baby sucks all the nutrients that you had out of you. Women have died from this. So this is not something like, oh, you're just throwing up in the morning, everything will be fine. It can throw your organs into failure, liver failure. A lot of times it messes up your gallbladder. Here's some other things. It can make you pass out because if you throw up all the time, you don't have, your blood pressure is probably really low, right? Because you're dehydrated. it's a supportive care thing, you know, the biggest issue is managing the dehydration, making sure their airway is intact and appropriate. I've seen women hospitalized for this. I've heard of women that have died from this. There's a lot of times where women get like PICC lines so that they can self-administer IV fluids at home because they are so sick and going in and out of the hospital every 3 days. It's just not the way to do things. And part conditions causing hemorrhaging. Okay, that's random. Okay, so spontaneous miscarriages are known in the medical field as spontaneous abortions. There's things like placenta previa, abrupto placenta, which means that your placenta ruptured. Placenta previa is where you have part of your placenta over that cervical opening, either part of it or all of it, and it causes bleeding as the cervix dilates. A ruptured uterus would be real bad. I mean, obviously that sounds pretty terrible. And an ectopic pregnancy is a pregnancy anywhere but the uterus, and it can be in the ovary, it can be in the fallopian tube, it actually can be outside of the uterus entirely, which is kind of wild. All of those, there's no way to save any of those. That is all results in a either medication-assisted abortion or surgery. They will, that very easily, this type of stuff, when it's in your fallopian tube, the ectopic pregnancy can very easily kill you. So it's not a,
I was just gonna ask.
yeah,
So it says that like there may be bleeding like coming out of the vagina, but
Yep.
there might not be, so I was just kind of wondering what the signs would be in the case of.
so a lot of these would be abnormal abdominal pain. The ectopic pregnancy that's in a fallopian and an ovary, a lot of times will be like real severe. It starts out kind of dull and it'll increase mostly on one side or the other. And it'll just keep increasing until, you know, they start bleeding, it ruptures, then there's a lot of blood. It's always preferred to catch that before. So if you have a female in childbearing age who has an increase in one side or the other of abdominal pain and they're sexually active, even if they say there's no chance that they're pregnant, there's a chance they're pregnant. So a question that we ask, they used to tell us to ask, you know, is there a chance you're pregnant? Don't ask that. Ask them if they're sexually active. Because if they're sexually active, there's a chance they're pregnant. It doesn't matter if they're on birth control, none of that matters, there is a chance. So you have somebody that presents to you with, you know, one-sided or the other-sided abdominal pain that's progressed, they're getting worse, they're diaphoretic, they're hypotensive. Those are all red flags that there's probably something serious going on.
They can also often point specifically.
Yep, it's very,
Whereas like, so say it's like, if you're thinking, oh, they have appendicitis or something else in the abdomen, that can be a very diffused pain, and they're like, oh, it's just this side, they're gonna go, it hurts
right
here.
here.
And it will be a very isolated, like, and it doesn't match, it's unilateral, and they'll point to it, so you'll definitely get that, like.
Yeah, there's other conditions that can cause pain like that, like a ovarian torsion where the fallopian tube twists. Same thing, right here, this is where it hurts. So both of those are very serious emergencies. But this torsion is not usually typically associated with being pregnant.
For guys in the room, think of it as testicular torsion with
Yep.
your testicle twists, it would be the same thing with an ovary, and if you think you're having a tumor essentially grow on that to the point where it can rupture and it's outside of that, that would be the pain sensation that you can feel in that area.
So a miscarriage, like I said, is also called a spontaneous abortion up to viability, which is I think 22 weeks at this point, but they call it a spontaneous abortion before 20 weeks. Typically, if women are going to miscarry, it's before 12 weeks, which is the first trimester. A lot of symptoms for a miscarriage would be there's bleeding, they have cramping in the lower abdomen, sometimes in the back. Moderate to severe bleeding, it can be a little bit of blood, it can be a lot of blood, it can be dark, it can be light. If the miscarriage is happening as you're there, there can be passage of tissues that don't look just like regular blood, it's like clumps of tissue. We talked about an ectopic pregnancy. So like I said, it could be kind of anywhere. The most likely is that it's in the fallopian tube, it didn't make it into the uterus. But it can kind of be anywhere, which is very strange. Babies growing in your abdominal cavity instead of in the uterus. There are cases where women have term babies growing in their abdominal cavity. Now, I don't know how it got missed. It's kind of wild. Probably didn't know they were pregnant, which happens. But not a huge amount of people. So when we talk about ectopics, you can get shoulder blade pain, and does anybody know why that is? So if you have blood in your abdominal cavity, your body really doesn't like that. It doesn't like that sensation. So you can get what's called referred pain into your shoulder because your diaphragm gets irritated by blood, and so you'll have this like, God, my shoulder just really hurts. It's really bothering me. I have this abdominal pain, but my shoulder is killing me, and you're like, what the heck? So if you get blood up around your diaphragm and your peritoneal cavity, your body doesn't like that. It gets irritated by that. And so some people get pain into their shoulder or into their shoulder blade.
That's weird.
It is weird. The human body is very weird. We'll just say that. It does a lot of weird stuff. So these are kind of the start. The shoulder pain, that type of thing, it would be a real late sign. That would be something that you would see right away. Obviously, if they're bleeding, they're going to have a decrease in blood pressure. I've never had anybody have a palpable mass in the abdomen. Not saying that it can't happen, but usually it's pretty early. An ectopic happens pretty early in the pregnancy. It's not something that, you're 26 weeks and have an ectopic pregnancy. It's like a before 12-week type of situation. Supplemental oxygen, if their stats are 94%, treat them for shock. Placenta previa. So the placenta, you have your uterus, you have your cervix, and that placenta, so the baby's in there, in where it's supposed to be, and your placenta's typically supposed to attach to like the side or the top or in front of the baby. So say I was pregnant. A lot of times it's not down by where the cervix is. If it's down by where the cervix is, they will typically do a C-section because as that cervix dilates, that placenta starts to bleed. And so they call it a previa. So you can have a complete placental previa, which means that the placenta is completely covering that cervix, or you can have a partial. And a lot of women in their 20-ish weeks of pregnancy will have where their placenta is partially over their cervix or real close, and the doctor will wait and rescan them because as that uterus grows, it'll kind of pull that placenta up away from that cervix. Sometimes, not all the time. So the bleeding doesn't hurt, but it can be a pretty substantial amount of blood.
So would that be something that they would like find in your stool or something?
So that would be like you're in labor. I mean, this is something they would see on ultrasound long before, if you have ultrasounds long before you go into labor. But if you get in a situation where somebody either is not having any prenatal care, is not, didn't know they were pregnant, and they're having pretty significant amounts of bleeding, it would be a pretty good guess that that's what's happening. And that would require a C-section because that baby's not going to push around that placenta.
It will also be bright red blood.
Yes.
If it's bleeding from if it's a placenta previa, it'll be bright red versus, you guys will talk about another condition where it's dark, like a deep color red. It'll be that bright red that you see in this condition. It'll be a good indicator of that as well. They could actively be laboring as well, and they can't progress in their labor because it's covered in the cervix.
Would the dark red blood be worse?
Yes.
A worse situation?
Yeah. Yes. This is like a lot of blood. The more, the further they are in their labor, the worse the bleeding is. So that's what it would look like. So that placenta is covering that cervical opening and that baby can't get past that, right? So the contractions are happening, the baby's rubbing their head all over that, and it's really irritated and it can tear, the placenta can tear, which is a whole another super fun. Abruptal placenta, so this is with the placenta separates from the uterine wall prior to the delivery of the fetus. That's bad, that's real bad. That is a super fast way to kill a baby because they're now not getting oxygen, okay? So they also will bleed like crazy. So you have severe hemorrhage with hypovolemic shock.
A common place you might see that one would be a car accident.
Yep.
There's one first, and mom's pregnant, and they had a sudden stop in that shearing motion, you can have that placenta rip.
And it
Moms
can,
are very good at protecting it, but it is an injury that can happen.
it can have a little bit of abrupt, like it can pull off a little bit, and there'd be only a little bit of bleeding, but it would consistently bleed, or the whole thing can come off. A little bit of separation, that would be a C-section as fast as possible, because you don't want that placenta to come off the wall before that baby comes out.
And it's most common with like a direct hit.
This can just happen spontaneously. But if you, I'm just thinking for first responder example of a place that you might see it, the way the seatbelt sits, right, or mom, and that kind of a thing, and then you have that sudden impact and stop, it's that shearing motion. And so it's not necessarily that she's been hit, but it's that aggressive back and forward, that whiplash motion that causes that shift and it pulls, right, unexpectedly. And so that can cause this to happen. But otherwise it can actually just happen. Infection can cause it. If mom falls or hits something, that can cause it. Sometimes they do just sporadically, the body is just not handling the pregnancy well, and it can happen. So there's a lot of different reasons, but frequently when we see them in EMS, it is because there's been some sort of a trauma, oftentimes is
Again, treat for shock, administer oxygen, those are the things that you guys are going to be able to do. There's no way to stop that bleeding, you don't apply compression or do anything to that manner and get them to the hospital. A ruptured uterus, so this has a super high mortality rate for both mom and baby. The only time I've seen anybody survive a ruptured uterus was when they were in the hospital, and even then still it's a race against time here. So essentially that uterus has a weakened wall of some sort. It can be from having a lot of babies, it can be from previous C-sections. So a lot of times C-sections, when they cut you, they do a horizontal incision. They used to cut vertically, and a vertical incision weakened the wall of that uterus more significantly, and that's why they didn't want people to have vaginal births after they had C-sections. It weakens, if you think about you stitch something together that was once whole, it's not quite as strong as it was.
It's also why they cut on the bottom of the uterus and
Yes.
the top, so that it doesn't rupture up the top as the baby grows. That pressure as the baby grows is still sitting lower, and so typically that C-section scar is going to be lower to assist.
Yes. So if this happened pre-hospital, I'll be blunt, the likelihood of survival for mom and baby is pretty slim. It is the two that I've seen, the rupture was extremely painful. They were in labor. It was the worst contraction they've ever had that didn't stop. And that was kind of a clue in to me, something's wrong. Because usually contractions are about a minute long. And this was contraction and it peaks up and it just kept going. And it was 2 minutes and the hospital took over and took her into a C-section. But it was something's wrong. And she felt that, like she had that impending doom, like there's something happening, something's wrong. This is not normal. You know, trust your patients when they say stuff like that. So, you know, there's an example, that baby's head's poking out through that uterus. Not a great time. That is, it can happen, like I said, it can happen from a frail uterus. So there's people that have, 5, 6, 7, 8, 9, 10 plus babies. Your uterus gets a little tired of carrying babies at some point and can become frail. But the ones that I've seen were because of C-section. They tore at the C-section scar. Not it. Right, that's exactly right. Here. Now, haha, it is you.
That was elderly too.
Abdominal trauma can cause it. Previous C-sections, prolonged difficult labor because your uterus gets tired after, so many hours of contracting. But it's that constant severe pain that kind of clues you into that this is happening. It's not like a wave, it's not like oh, that hurts. It's like, oh my God, it feels like something ripping them apart, which is essentially what's happening. Okay, well, apparently you guys just treat everything with oxygen and drive fast, because that's all it's telling us.
So one thing to remember with this, you guys, is when it comes to deliveries and childbirth, we never insert fingers, hands, anything of that nature if they're bleeding, right? So a lot of times people are like, oh, do we need to
Stop the bleeding.
at most, you're gonna apply like an abdominal pad in the vaginal, like externally, just to cover and catch blood, but we are never inserting anything, we're never doing anything of that nature.
Correct.
And
Just stay out of there, essentially.
That is for people that get paid off mark in other areas, we just transport that stuff.
Yes,
Just stay out.
just stay out.
Stay out of it.
Right.
So you tell you that they are delivering, you ask them, do you feel like it's imminent? And then you might go, can I take a peek and see
Right.
if I see the baby's head?
One of these,
No? Okay,
lift the
that's
sheet,
fine.
oh, yep, there's
That's
baby
fine.
coming. Right, so, you can have hypertensive emergencies in pregnancy,
I'm sorry.
which can cause seizures, which is terrifying. Somebody seizing when they're pregnant, that's pretty scary. Because you're like, well, not only are you affecting you, you're affecting that unborn child. It's the same care, you put them on their side, protect their airway, give them oxygen if needed. Pregnant women laying flat on their back especially if they're term, can put pressure on the arteries in their body and cause decreased oxygenation to that baby. So a lot of times we try and offset mom a little, kind of put her up on her side, either side, left is preferred, but either side works. Just don't have them laying flat on their back. For one, they won't be able to breathe very well because, there's a baby. But
Is there a reason for the left side?
so it's just the way that your anatomy is. A lot of times so you're pregnant, you have a baby, and your aorta runs, and it's a little more off to the right. So when you put them on the left, you get a little more clearance, but not everybody's made the same. So sometimes left versus right. Doctors always tell you to sleep on your left side when you're pregnant. Well, sleep however you can sleep at that point. But it takes the pressure off of those important blood oxygen carrying structures.
Yeah, that's.
What is it, Renee?
She's not in here,
Oh.
I'm waiting to ask.
Yeah.
To see how many days you're in.
Right. So there's something called PIH, which is pregnancy-induced hypertension. This is something that happens a lot of times with first pregnancies. It is not like, holy crap, they're gonna have a seizure emergency. This is, your blood pressure's a little elevated. It gets better when the baby gets delivered. They kind of feel a little crappy, but you don't typically treat this with medication. Preeclampsia, on the other hand, preeclampsia is, that's interesting, I didn't know that, most likely to affect women in their 20s who are pregnant for the first time. Weird. So preeclampsia is a lot of different things, but essentially it's very high blood pressure, it's protein in their urine, which is something that the doctor would know, not you. But preeclampsia can lead to eclampsia, which causes seizures. It's quite dangerous as a hypertensive emergency.
Is it rare?
No. Preeclampsia is not super rare. You'll hear a lot of people that said, well, I had to be induced because I was preeclamptic, which just means that they had risk factors or were headed towards the path that could have led to eclampsia. And eclampsia is much more significant and dangerous. Let's see.
Blood pressure reaching 160.
Yeah, I think it's 160 over 100.
They're at the threshold where it transitioned from preeclampsia to eclampsia, and they started administering medications to prevent that seizure activity from happening. Because they will actually go into status epilepticus, where they just continuously seize until that baby is removed, because
Yeah.
it keeps the pressures too high.
And you can also get preeclampsia after you have your baby. So that's why they monitor blood pressures pretty frequently after. It can be, I think it's up to a week, or it might be longer than that. 6 weeks. Up to 6 weeks, you can have complications from preeclampsia. It's postpartum preeclampsia.
And they have said that there's been some cases, 6 weeks is common, up to 3 months.
Yeah, that's wild.
Yeah.
A lot of times these are the women that have like their ankles all of a sudden are this big, their blood pressure is really high, then they check their urine for protein, they have protein in their urine, and they will typically schedule an induction if needed.
These, the women who are bedridden?
No.
They can be in the hospital, it depends. That typically is like preterm labor type of stuff, more than preeclampsia. If you get admitted with preeclampsia and you're like earlier than 37 weeks, they'll typically send you somewhere that has a NICU and take that baby. Because it's better the baby's out in that situation.
Oftentimes they watch you through your pregnancy, that's why they take your blood pressure so much.
And
you
pee.
use that
You have to pee a lot.
Your third trimester, where it will shoot up and you'll see the preeclamptic symptoms. And they have women checking their blood pressure multiple times. My sister was preeclamptic, and so she got sent in and they induced her early because she was getting to that threshold where they were concerned about it. So they watch it very closely. And then after they delivered, they started calling the 3 months immediately after delivery the 4th trimester, because of the changes the woman's body struggles to go back to pre-pregnancy state. And so that's where there's still a lot of changes happening in the body. So they might be ambulatory and doing okay, it's just the shifts because of the hormones and the different hormones that cause different chemicals to respond in the body that can cause them to still become incarnate.
And they'll typically, the biggest sign is they feel like crap at home, like worse than you would just typically after having a baby. And their blood pressure, they go in to get their blood pressure taken and it's excessively high. And that's kind of one of the, and then they have to be put on blood pressure meds until it gets better. Let's see. Those are kind of the symptoms that you see for somebody who's preeclamptic. A lot of them are, the swelling. Women get swollen, their feet get swollen, their fingers get swollen, their face gets swollen. This is like, their legs get swollen. This is excessive. This is like, go ahead.
I've definitely heard of cases, I don't know if it's with preeclampsia, but I've heard of, there was a teacher of mine that, this is a few years ago, they put her up in the hospital bed, so her feet were like,
Yep.
in the air. Yeah.
So in Trendelenburg,
Yeah.
to keep that baby in. So you can have conditions where you have an incompetent cervix, so your cervix isn't doing its job of holding that baby until it's done cooking. And so if you go into labor after 21-ish weeks, they'll put you in the hospital on bed rest, and they will literally flip you so you're almost standing on your head to use gravity to keep that baby where it's supposed to be, so it continues to cook. So that absolutely can happen. It's a very strange thing to see when you walk into a hospital room and the mom is feet up in the air, you're like, what in the
I
heck?
think it was 21 weeks, so she was in that position for how
A long time.
Uh,
They can
she's
also
been
do,
babies after that.
you can also do a cervical cerclage, which is literally stitch your cervix closed, which, that sounds horrific. But it can help keep baby in to finish breeding. So, hey Renea. So, this is what I was talking about with laying somebody flat on their back when they're pregnant. The weight of the fetus compresses on that inferior vena cava.
You know,
And-
right here,
It can make them hypotensive and it decreases oxygen to that baby. So that's why you try and kind of push them off to the side. These get better if you move them. They get better if you sit them up a little because it's called supine hypotensive syndrome for a reason. They are supine and hypotensive. Change their position. What do you do? Oh.
I'm looking at it.
she put a picture on the back.
So essentially that's what I was talking about. It compresses that. Oh, here.
Can you demonstrate where that is, Renee?
Chuck?
Here, get this.
There was a situation one time where we were asking Renee some questions, and she had to, she
Make
tried
some
to explain what
hand
it was.
gestures.
It
She made a hand gesture that was very,
Hysterical.
It's like the Vita came was right here.
only she was just doing it down here and very low.
Yeah.
It was really
Explaining
funny.
the situation
Yeah.
about people.
I almost died. I was laughing.
Do the math on that. She wasn't catching on, she turned a couple shades of red, and now it's our funny story.
So Renee's beautiful heart picture. This is where that vena cava is. Okay? Oh, so. We talked about this. So sticking on like a blanket behind, because it's really hard to kind of stay up on your side, especially on an ambulance cot. So like sticking a pillow behind their butt or a rolled up blanket to kind of hold that position works really well.
Is it propped up at all, the cot?
You can have a little bit of a head elevation, but it's kind of hard to be elevated head when you're on your side, you know, because you kind of be like this. I don't know why they're teaching you this, it's kind of strange. So they used to tell it, I don't know, what time is it? Sure, we can take a break.
Jason.
I'm like, what are we breaking?
Phones?
Well, are you okay after the burn?
Yeah. Start raising my butt. We're missing something, so I'm gonna wait a second.
No, actually.
So they talk about manual displacement of the uterus. Essentially, that just means that you take your hand and push the uterus off to the side. So if the patient needs to be on their back for some reason, moving that uterus over a little changes, it's not on the vena cava. They are recommended, so they used to tell us when you're doing chest compressions on a pregnant woman that you were supposed to kind of prop them up on their side. Well, now they're telling us to leave them on their back, but have somebody try and move that uterus off the vena cava so that they get good blood return.
Would it like stay or?
No, you have to
You
hold
have
it.
to just hold it.
Yep, you just have to hold it.
And we can do that as EMRs?
Yeah, well, yeah, just don't like, I mean, you're not, it's not like a, right, you're not like moving the belly off the body, it's just like a, you know when you were pregnant and you just kind of push your baby out of the way because they were in the wrong spot?
When I was pregnant, I lifted and put my belly on the counter. 'cause
Right,
it helped. So-
same, but off to the side, okay? Like just rest it wherever it'll go. So one hand or two, whichever you prefer. So like I said before, any female, and it actually could be less than 12, which is very scary and sad to think of, because there are young girls that are getting their periods before the age of 12. So they could get pregnant as soon as they start getting a period. So that's why, you know, one of the first questions you ask about somebody is, Do you get a period? Have you ever had a period? And are you sexually active? Because they could be pregnant even if they say no. Because typically people are like, no, I couldn't be pregnant. Absolutely not. And then they are. Your assessment is going to start as the same. You know, you're verifying your airway, breathing, circulation, your mental status. Your secondary assessment would be gathering a history. How many times have you been pregnant? How many living babies do you have? That's your gravida and para. It's okay to feel their belly. You're not going to hurt that baby by palpating on their belly. You might feel a baby. That baby might hit you back. You know, like, it depends on what you're doing. Always get a baseline set of vitals. Here, appropriate.
That's an ambulance.
Okay, appropriate questions would be, have you ever been pregnant before? How many pregnancies have you had, which is gravida? How many pregnancies resulted in live births, which is para? Have there been any previous complications? So have you ever had preeclampsia? Have you ever had a miscarriage? Have you ever had an abrupto placenta? Have you ever had, you know, there's all sorts of things that could have happened, and typically they're going to know that. I mean, your last normal menstrual period would kind of give you an idea of how pregnant they are, if they don't know, but I don't ever expect you guys to calculate that.
Can I ask an odd question?
Sure.
Is there a difference of importance between, like, cause people have asked me too, like, how many, like, viable pregnancies have you had? Like, do the non-viable ones or the non-live births, like, not that they don't matter, but are they just?
They do matter. It gives us a better assessment of risk.
Okay.
For future miscarriage or future baby death, essentially. So if you've had, you know, 3 living babies, but you've had 8 miscarriages,
So.
and they're pregnant now, their risk of miscarriage is higher.
Oh, wait, okay. So then, like, how many pregnancies have you had? 7. How many were
Living.
live births? 4. Okay,
Right.
That, never mind.
Yep.
That answered me.
And there, you know, there's going to be all sorts of variation of answers. They could have been pregnant 15 times and have 1 baby.
Yeah.
So that tells you that they, you know, have had that many miscarriages or that many unsuccessful pregnancies, which puts them at a higher risk of something bad happening
Yeah.
with this pregnancy if they're pregnant now. We talked about all this stuff already. These are your assessment. Your treatment of these patients is not going to change compared to a non-pregnant person beyond the supine thing. Like, don't put them on their backs. If they're in shock, you're going to treat them for shock. You're going to give them oxygen if needed. You know, like Katie said, we don't put anything inside anybody's vagina because we just don't. We just leave that alone. There is one caveat to that we'll talk about, but we're not talking about it yet. Your vital signs, you know, if they're stable, you do them every 15 minutes. If they're unstable, you do them every 5. It's really important to maintain mom circulation. So worst case scenario, mom dies or is actively dying while you're there, and she's 38, 39, 40 weeks pregnant. Doing CPR on her keeps blood flowing to that baby. So though it could be something super traumatic, like mom's not going to survive this, there's a chance that you could save that baby by doing chest compressions and good CPR. So it's important to do. You know, the example would be like mom's in a car accident. Okay, mom didn't survive, but she's super pregnant. You're gonna do chest compressions to try and save that baby. Oh God. We're gonna skip that because I can't read it. Why is that so small? Okay, so labor and normal delivery, which like I told you, is much higher, up in the 90%, is like babies just are born without any intervention from anybody. So typically what happens, contractions start, you can have contractions irregular contractions that start. As they get closer, typically they become pretty timeable. A lot of times they'll say if your contractions are 2 to 3 minutes apart and they're lasting more than 45 seconds, you're getting closer to having your baby, and if you are at home at that point, you probably should go to the hospital if you're planning on having a hospital birth. So there's stages, the dilation and effacement of the cervix. So essentially the cervix will expand to 10 centimeters typically, and it will thin out. So your cervix is kind of like a, I don't know how to explain it. It's like a, I don't even have it's a plug essentially, right? But it's got a little hole in it. So as it dilates, it gets bigger, but it thins out that ring around it so that baby can get through there. What a terrible term for that. Expulsion of the fetus. God. How about delivery of the fetus? So that would be the next. And then the next part is when the placenta is delivered.
Terrible description.
Right? Expulsion? Jeez. So first stage is like when the first contractions start, the cervix starts to dilate. Second stage is when the expulsion happens, when the baby is born, and your third stage is when the placenta is born.
Who named these
So-
stages?
Probably a man. So these numbers are a little skewed, I'm gonna just tell you that right now. There is very few first-time mothers that only have 8 to 10 hour labors. That's pretty fast. Typically, first pregnancy can be anywhere upwards of 24 hours total. Second pregnancy, a lot of times, is half that time, because your body's like, oh yeah, wait a minute, I did this once. I feel like I know what I'm doing. And third babies are wild cards and can either be as long as first, can be the same as second, can be way shorter, and then beyond that, sometimes I think they just come out. So we talked about the end of stage 1, right before baby comes, 3 to 4 minute intervals for those contractions. Sometimes it's a little closer together. And at least 60 seconds, they're lasting, and they're very, very intense. Braxton Hicks contractions are not labor. They are a tightening of the uterus, but they do not cause any dilation of the cervix. So, and they're not typically super painful. They just like tighten, and then they, 30 seconds or so, then they kind of go away, but they are not labor. Blah, 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 we talked about this. So your duration and intensity, this is all stuff that you guys probably really don't need to know. So we talked about the cervix. Okay, see, I didn't know how to describe that. But it's thick, and as you dilate, it starts to thin out, and
It's like a balloon.
yeah,
Comes
Yeah.
Coming out of the balloon.
correct. So it starts to thin out and spread out, essentially. And so then, when you get to 10 centimeters, it's when the baby's head starts to come through that cervix.
Just a lot more pain involved.
Correct. This is how you time a contraction from the start of the contraction to the start of the next contraction. Again, I'm not exactly sure why we're telling you that.
Oh, I was gonna ask, like, how do you, like, never mind, stupid question.
Nope.
Time the contraction.
So typically, you're not going to be there timing contractions, because unless that baby is like, you can see the head, you aren't going to stay there and deliver that baby. They will be moved to the ambulance, and you will be on your way to the hospital. Because we have such long transport times, could you time contractions to tell to the staff what's going on? Yeah, you sure could, because you got time, but not super important in the long run. Second stage, your expulsion stage. Your contractions are less than 2 minutes apart. They last 60 to 90 seconds. That's how you know that baby's coming, right? And moms will know. They will definitely know. A lot of times they will feel like they need to go poop. Like there's so much pressure down there that it feels like you have to poop. they also get a little squirrely, like they don't wanna be just sitting, they wanna get up and move, or they wanna change positions, and allowing a woman to change positions when she's in labor usually makes, delivery of that baby much easier, because your body instinctively knows what needs to happen to your body to get in the position that's needed to have that baby. So, I'm gonna talk about home birth a little bit, because that is something that happens with home birth. You get to be in a position that you're comfortable in. It is letting the woman's body do what it's supposed to do. Hospitals a lot of times have women delivering on their backs. And as I'll show you with this lovely mannequin, when you're delivering on your back, so your pelvis, right, you have a hole in your middle of your pelvis, and as you're pushing that baby, you actually push the baby down, and then you have to push them up. So the position that women deliver in a hospital is much more for the doctor than the patient, because the doctor can see what's going on. It's much harder to deliver a baby like that, and also your pelvic your pelvic ring is in a smaller position than, say, a squatting position, a kneeling position, having your body upright and using gravity. So that's my little spiel on home birth versus hospital birth. So there's a bulging in the perineum, which means that that baby's coming. So crowning is when all of a sudden you'll see a little bit of a baby head. Then you have to stay there. Don't try and put him in the ambulance at that point.
Oh, like they're crowning?
Correct. Because typically, this doesn't take super long. Once the head starts coming out, it typically doesn't take super long, and nobody wants to deliver a baby on the side of the road in an ambulance, or on the cot on the way to the ambulance. That doesn't sound like a good time to me. In the home is a much more controlled environment. You can have all your stuff laid out. You know, mom is more comfortable, even though she might be telling you that she just wants an epidural at this point. Probably not going to happen. We do not suction babies. And there's a caveat to that. So bulb suction, like you see on TV, or if you've had your own kids, you've seen them shoving that bulb suction down into their mouth, into their nose. You're actually causing trauma. It can also cause the baby to brady down, because it's stimulating that nerve that runs down the back of your throat. So we are not routinely suctioning babies as they're born anymore, because when they're born, right, so they're coming out face down and they rotate, and as they're born, you keep their head lower, and all that nasty stuff comes out of their mouth and nose as you have them head down, right? There's reasons to suction, and one of them would be like if there was meconium, which is when the baby poops prior to birth, so they're poop in their amniotic sac, so then the fluid that's coming out is like green and nasty looking, then I would suction, because you don't want that stuff to go into their lungs. But yes, they are routinely not suctioning, or evidence-based medicine is telling people that this suctioning, first off, is too aggressive, and it's causing harm as opposed to doing what they think it's doing. As that baby's coming out, their head is out, right? Their head might have fluid in their throat, they might have it in their nose, but they're being compressed, like as they're coming out, the lungs are being compressed, the shoulder, everything's getting squeezed out. So it's not like they're just hanging out with fluid in there. So you don't want somebody to, deliver a head and then slam, push that baby out. First off, it's going to cause damage, and it's not super great for the baby either. So as that baby's being born, and again, I'll show you, you don't push back, obviously. We never try and push stuff back in. You just support that head as it's coming out, so that it doesn't come rapid fire flying out, because it happens. You aren't going to have to do this in a normal birth. You aren't going to have to manipulate this baby. That mom is going to be able to push that baby out, and all you're doing is literally supporting that baby so it doesn't fall onto the bed, right? You're not pulling up, pushing down. You don't have to do any of that.
Just catch it.
Just catch it. Don't let the baby fall on the floor. And they're slippery.
Oven it?
So you're supporting that baby, and like I said, this picture's not great, but you want to keep that baby's head lower than its body until it comes out, because again, that helps drain that fluid out of their airways. We're gonna ignore that too, because the first thing you're going to do is you're gonna put that baby on mom. Even if the baby's not screaming, not doing anything, you put that baby on mom, because mom's warm. That's where baby came from, right? The scent alone of mom sometimes causes enough stimulation, and mom's gonna be touching baby and doing all these things, right? You're gonna put a warm towel on them, dry them off a little. That's typically enough stimulation to get them to cry, to get the rest of the crap out of their airways and start expanding their lungs. We are not going to cut the umbilical cord, okay? We're going to leave the umbilical cord attached for if everything's going well until the placenta delivers. Because the blood volume, if you think about what's happening to that baby, right, it's being squeezed. So where's their blood volume going? Back up that umbilical cord into that placenta, right? So that baby comes out, and they've just been squeezed, and the first thing that somebody does is clamp and cut that umbilical cord. Where's all their blood? It's in the placenta, right? We want that blood. That's nutrient-dense, good stuff. That needs to be in that baby. So a lot of places are doing delayed cord clamping. They consider waiting 5 minutes delayed. I consider waiting 5 minutes not delayed. I want that umbilical cord to be flat and white and pulseless before you even consider cutting it. Because all of that blood will come back to that baby, and they will have way better outcomes. And they look better. Like, they oxygenate better, they don't stay purple for as long. It's really important. The only time that should not happen is if you deliver baby, put baby on mom, and you have to do something to resuscitate that baby. Start resuscitation, and then have somebody clamp and cut the cord if you have to move that baby away from mom to continue the resuscitation. But if there's no complication, and there will be times where the baby has a cord around their neck, and people kind of panic about that. You can have one cord, you could have, wrapped once, you could have it wrapped twice. It's called a nuchal cord. A lot of times, as that baby's being delivered, you can pull that cord out from around their neck. You don't have to cut it. Very rarely is it like so tight that it's like wrapped around their neck and it's like a noose. Typically, you can kind of maneuver and manipulate it to get out from around their head. You don't have to clamp it and cut it. There are times where the cord can be really short, and that's like an abnormality. That would be a different situation. Then that would be you need to clamp and cut the cord because the baby can't get out if the cord's really short. And you'll see mom will be pushing and there'll be like baby's trying to turn around and go back in because they can't get any further out because of how short the cord is. So placental delivery, typically it happens within 5 to 20 minutes. That would be totally normal. We never, ever, 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 ever pull on an umbilical cord to deliver a placenta. Because what will happen is you will deliver part of a placenta or the cord will snap. Bad news. That's how we hemorrhage. That's how we don't do well postpartum, because you're pulling that placenta off of that uterine wall when it's not ready. When it's ready, it'll disconnect on its own, and she'll have contraction feelings again, and you tell her to bear down, and you can hold the cord with not pull it, but a little bit of traction, and as she pushes that placenta will come out. Sometimes you don't have to do anything. Sometimes it'll just come. So, again, do not pull on the umbilical cord.
Is there ever a time where, say you've been waiting 30, 45 minutes and the placenta still is not delivered?
So, that should be a time where they should be on the way to the hospital.
Okay.
Is it life-threatening at that point? Typically not. Women, the other thing is there's going to be blood, okay? There's going to be blood. Blood is normal. Up to 500 mLs of blood is a pretty normal amount of blood to lose when you have a baby. If they're soaking through Chuck's pads, like the pads that they put under their butt, you soak through one, you get another one, there's more, it's not slowing down. It's this This is a lot of blood, and I don't know if you've ever like seen blood pooled anywhere. A little bit of blood looks like a lot of blood, but it's a little more than like, I'm not real comfortable with the amount of blood that's happening. Typically what that means is that uterus isn't shrinking back down. And so like feeling where that, you'll be able to feel where the uterus is, and after you deliver, your uterus should be at their belly, their uterus should not should be at their belly button and should be pretty firm feeling, you know, after the placenta starts delivering. If it is not, if it like feels really soft and boggy, typically there's blood clots in there, so this is on the way to the hospital, we're not messing around here, go to the hospital, they will know what to do from there. But that's typically why they're bleeding, because the uterus isn't clamping down to stop that. And that can lead to shock pretty quickly. So if your patient doesn't look good, if they're pale, they're tachycardic, after baby's born, they look shitty, right? Don't mess around, because you can lose so much blood just from the uterus and the placenta alone, like the placenta tearing off. It's not going to take much. So if they don't look good, they're not like recovering quickly, because you know you're going to be tachycardic when you have a baby, you're going to be sweaty, but like they should start looking better. And if they're not, you should be moving a little more quickly to get them to the hospital. There's going to be times where mom delivers the baby and you're there to bear witness and they don't want to go to the hospital. Can you make them go to the hospital?
No.
No. Can you encourage them to go to the hospital? Yeah, you sure can. But you can't ever really make anybody who's alert and oriented go to the hospital. So as long as everything looks okay,
what if it
encouragement.
comes down to, like you said, they just start to not get better at all and it seems like really, really bad?
So there'll be
But
a
they're like,
time,
don't ever take, you're like, don't take me there. But then it's like, if you don't, you'll die, basically.
and you tell them that, right? Like, hey, you're not doing well. Something is going on, we need to get you to the emergency room. And I know Jason's talked about like implied consent. So when they go unresponsive, then they don't get an opinion anymore.
Fair enough.
So sometimes it takes waiting until they are not able to make that decision and then transporting them. So in that situation.
Okay.
So determine if delivery is imminent. What that means is if you look under that sheet and you can see baby head with hair, you probably shouldn't try and load him in the ambulance. It says it's best to transport a mother in labor so the delivery can happen in a hospital. Sure. They don't take into account how far people live from hospitals. So there's a reflex that women will get when they are having babies, and it doesn't always happen, but it's called a fetal ejection reflex. And essentially, it's actually what's supposed to happen. So, but women have no control over that. That literally is your body bearing down and pushing that baby out without you doing anything. It's a very strange thing to witness, but if that's happening, that baby's coming soon and you probably shouldn't be trying to get in the ambulance. A lot of people, because when we teach this, you know, all this scary stuff, right? And we'll talk about more scary stuff after this, but they're like, oh God, I absolutely do not want to do this. I don't want somebody having a baby at home with just me there, that freaks me out. So they'll be like, it's probably okay, we'll just put him in the ambulance and go. It's better to deliver not in the ambulance. Much easier. Think about having a baby on the ambulance cot, right?
And all the bumpiness on these roads.
Oh.
Better than a cab.
I can't even.
I mean, better than Uber.
Right.
Imagine being an Uber driver constantly.
So one way you can kind of tell how far along somebody is by where you can feel their fundus, which is the top of their uterus. So if they're top of their, when you feel a pregnant belly, you know, you feel like this firm structure. And if you feel right at the belly button and you feel the top of that, they're probably close to 20 weeks. If it's way up here and that's where you feel the top of it, they're probably closer to term. If there's more than one baby in there, That's a totally different situation. Because they're like, you know, big pregnant. There. This would be why you would have a baby at home. Natural disasters.
Cranberry trucks spilling cranberries out.
Lots of snow and you can get out of here.
Right. So again, like we talked about, if they are like, I need to poop, that baby's probably coming. So, the strong urge to push can either be like, I just really need to push, or they'll be like, I'm not doing that, and that baby's coming. If they're contracting, their belly's gonna be hard. There. You're not a love patient. Okay. We talked about don't put anything in anybody's vagina when they're having a baby. The reason they say don't allow them to use the toilet is because the urge to poop is actually the baby's head coming down and crowning, and having a baby on a toilet is a lot harder to catch.
Well, what happens if like they actually gotta use the toilet?
Well, then they just, so they'll just
They
poop.
do,
Shit themselves right then and there?
Yep,
sure do.
happens.
Don't tell them.
Because it's the same pushing, like the technique to push when you need to poop is the same technique to push a baby out.
Just be glad you don't have to do it.
Right.
If there ever comes a time, I will walk out.
You. It's the worst thing you see is a little poop, let me tell you.
I know, that's why I'm saying.
Don't try and hold her legs together. That's not going to do anything. Just saying, like, just cross your legs, you'll be fine. It's gonna be fine. Don't do that. Sterile vegan is important, but is it absolutely necessary? No. It's not absolutely necessary. Childbirth is not a sterile procedure. If
And
you're,
let's be real, that OB kit is not sufficient.
No.
You need towels, you need blankets, you
other
need
gloves, you need all
other
sorts of
things,
shit,
like-
right? You're not, this little box of gadgets is not going to be everything that you need to catch a baby.
10-gallon garbage bin.
Also, our gloves aren't sterile, right? And if all I can do is put on gloves to catch this baby, nobody's gonna complain. As long as they're clean.
Do you have gowns in the ambulance?
There's usually gowns in there, but yeah, we do. If you get the chance to put a gown on, super awesome. You can apply oxygen if you would like. A sterile field, yeah, sure, absolutely. A lot of times women will puke while they're pushing. So there's things coming out of all the ends. What, you know, puke up here, they're pooping, they're having a baby, it's messy. It's not a clean, sterile time.
And the baby has all of its stuff in the sack that is.
Right, it's just messy. It's messy. That's a really old OB kit, so we're just not gonna look at that. Tear the end, no, don't do that, Jesus. Again, we talked about applying like that gentle, you don't push, but just stability as that baby's head is being born, so that it doesn't come shooting out like a rocket ship. Because that will cause more damage than anything. So the explosive delivery is super detrimental to the mom, but it's also not great for the baby because they come out super stunned. Like, what just happened, right? And a lot of times they don't breathe on their own right away because they're shocked. They were an inside baby and now they're an outside baby and nobody like gave them a chance to acclimate to that.
It can also cause dislocations. So as the baby's coming out, the head naturally, as you're catching, you're gonna tilt kind of down and the baby should come out because those shoulders are coming behind, right? Baby's head is the biggest spot, but those shoulders can get caught up too. And so that shoulder width, if it's explosive like this, it can actually cause dislocations of shoulders.
Or break clavicles, break humerus. Think about what's happening in there and they're just flying out like that. Do not tear the amniotic sac. Don't do that. you don't have anything to do that with, we're just gonna cross that off. Babies can be born in their amniotic sac. Okay, so just don't do that.
So so can you say there's a high risk that babies can go into shock as soon as it's delivered for any reason?
No, I mean, if you have an explosive delivery, the risk is a little higher, because like I said, they didn't get the chance to kind of like ease into the world. And a lot of times those babies require a couple of breaths because they just come out and they're like, what just happened? But they are just too stunned to do the things that need to happen. They don't take the breaths, they're just kind of like, when they deliver at a slower rate, right, their body kind of acclimates on the way out instead of super fast. So, we're not gonna tear the amniotic sac. We talked about the nuchal cord. You know, the cord can be wrapped around once, twice, 3 times. Typically, you can maneuver it around their head. It's not, very rarely is it so tight that you can't get it off. We are not suctioning the airway unless it's meconium. So, when babies come out, they typically will come out face down first, and as they're coming out, their body will rotate naturally. Either way, they'll either, face left or face right. It's up to them. As they do that, the next time mom pushes, that top shoulder will come, typically. Top shoulder will come first, and then bottom shoulder. Not always. Typically. Like I said, they're slippery little suckers. Babies are slippery when they're coming out like that. So make sure that you're supporting that baby as they come out. You don't just kind of let them plop out. So occiput anterior is the normal position. That means that they're face down. That's preferred. It's easier on mom. It's easier on baby. This occiput posterior is a malpresentation, but it still happens. Typically, you'll see this happening, and mom will have the worst back labor ever. Like horrific back pain when she's in labor. That's because baby is upside down. They can still be born like this. It's a little harder because of the flexion of the head as it's coming out. Typically, they have to push harder. It's a longer labor. It's more strenuous on both mom and baby, but it is possible. We talked about this. Unwrap it. There's been times that I've seen babies come out that have nuchal cord, and as they're being delivered, the midwife would keep their head super low and the body would deliver. So like kind of flop them out this way, and then because the cord then is looser, you can unwrap it. Grasp the feet, Lord. Okay. APGAR scores. When you do an APGAR, you do them at 1 minute, 5 minutes. In the box there's usually either scissors or a scalpel to cut the umbilical cord along with clamps. But like I said, you don't have to do that for a long time. So they say 6-ish inches away from the baby is where you put the first clamp, and then you do like a couple of inches past that, and then you clamp again and cut in between them. So see how baby's up on mom there? That's where baby should be. One of the biggest things about babies is they get cold because, they're soaking wet and have been inside all this time and very controlled environment. So you get that baby out, put it on mom, and like dry towels. Pile on some dry towels. The warmth from mom will help that. Turn your heat up. If you're in the ambulance and this happens, you're trying to keep that baby warm. And they actually don't recommend putting hats on them anymore either. And a lot of the newborn kits, the OB kits will have hats in them. They actually teach us that, like taking saran wrap, I know this sounds crazy, but like saran wrap holds in heat. So if like baby's having a hard time regulating, like putting the plastic wrap on baby and mom to hold that heat in, works. I've seen babies, you know those big giant Ziploc bags, like the 2-gallon ones? I've seen babies resuscitated in those bags because it holds that heat in. Because you need to be able to see them to resuscitate them, right? You can't do that under all that blankets and towels. So they have them in literally a zip, not their head, just their body, in a Ziploc bag so that you can resuscitate. Like, just zip it shut, you'll be fine. No, their head's out, body's in the bag because it keeps them warm. And one of the biggest things with babies is they get cold, and then there's a cascade of things that happen when they're cold. So, right, no, don't put the head in the plastic bag. You could absolutely put, you know, a trauma dressing or whatever between mom's legs because there is going to be bleeding after. Make sure you write down what time that baby was born. It says to transport mom, newborn, and the placenta. That needs to come too. It's an important part. Okay. This is the exciting part. Here we go. Crowning. Okay? We talked about crowning. Crowning is when you can see that baby's head. This is the time that we are not going to the ambulance. Okay? We are staying right where we are. Because that baby is coming quickly. You do not have to touch any of that. Okay? There isn't a time that you're going to need to put your hands on anybody. The only time that you're going to be putting your hands there is to support that head as it comes out. Okay? We're not putting our fingers in there. We're just leave it alone. So head's born. See how that first it was face down and now baby's face is facing a leg? Totally normal. It looks like there's a nuchal cord there. Yep. So they could easily unwrap that cord. I don't know why it looks like they're pulling on that head. Don't pull on anything. Good Lord. There's more amniotic fluid, so that's shoulders. A lot of times after that second shoulder comes, the rest of that baby's gonna come. There isn't usually any much pushing after that. Like, push for the head to come out, you push for the shoulders, and then when the shoulders are free, baby just kind of, yeah, like a water slide. Okay, so see that umbilical cord? See how it's all full of, like, it's red and like thick and, right? That is full of baby's blood. So that is why we are not going to cut that. So take baby, put baby up on mom. Obviously, if the cord is a little shorter, you'll have to kind of keep baby lower on her belly, but typically, you know, mom will pull that baby right up on her. Dry and warm. This is talking about clamping and cutting the umbilical cord again. There's the placenta. We should have left that attached to something. So a umbilical cord will get like super skinny and flat and white when it doesn't have any blood left in it. That's what you're looking for. So blow by oxygen. If I have a baby that's born and they just aren't quite adapting to the outside world, like they're just not taking real big breaths or not breathing at all, but they're kind of like, holy crap, what just happened? I'm not going to do blow by oxygen. I am going to put the mask on and give them a couple of breaths, because what I'm doing is expanding those lungs, and then all of a sudden they'll start to cry. Sometimes they just need a little bit of help to expand things and get things moving in the right direction. It's very scary to put a mask on a baby and squeeze the bag. It feels like this is the worst thing that I've ever done in my whole entire life. But you do like 3, 4, 5 of those. They're called inflation breaths if you ever take neonatal resuscitation. It's literally, and all of a sudden the baby's like, whoa, what am I doing? And they start crying, and that's what you're looking for, right? Blow by oxygen doesn't really do anything for these little people. Also, their pulse ox reading, you're not going to jump and get a pulse ox because their pulse ox is going to be low, because when they're switching from mom's circulation to baby circulation, like a pulse ox reading in the 70s and 80s initially is not abnormal. I mean, it should kind of climb up as time goes on, but like high 80s, low 90s, not abnormal. Now, if they're in respiratory distress, like you can hear they're not breathing well, they're breathing super fast, those are different situations, right? But like a normal, like, I mean, that baby looks pretty darn good to me, so this might just be a demonstration, but did you have a question, Paul?
Yeah, how long would you wait to initiate the help of the breaths? Because I know it can take a little while for the baby to actually like.
Get their shit together? Yeah, so it depends how they look. If they're moving around and they're like looking around and, 30 seconds goes by and they haven't like really taken a good breath, because you're gonna be listening with your stethoscope, I would be like, okay, we're gonna give you a couple of breaths. If they come out and they're gray and they're limp, I'm not waiting that 30 seconds, right? Because after you like try and dry them off, a little bit of stimulation that way, if they're still not doing what they're supposed to be doing, I would be attempting at least resuscitation via bag valve mask initially. Because a lot of times, they just need that. There's a lot of times that they don't need CPR at all. They just need to be ventilated for a
This
little while.
might sound stupid, but do they, like, after the baby's delivered, dried off, everything's said and done, is the baby always gonna end up purple like that, or is that the sign of like? them
That's
not-
actually normal. So a lot of times you'll see like this part of them will be pink and arms and legs will be pretty purple. And it should start to fade over, minutes, 15 minutes. Sometimes like then their arms are normal color, but their hands and feet will still be kind of purple, pretty normal. It's just their circulation changing. And this is not a priority and these are not a priority, right? The body's like, this is what's important, this is what we're going to get blood to first. And then it just takes a little while to get out to the extremities. So that one looks a little purple, but not, that looks like a pretty healthy baby to me.
I have a question.
Yeah.
So can it happen that the amniotic sac is like obscuring their face and airway?
So if they're born in the amniotic sac, they are still connected to that placenta inside. So they're still getting oxygenation, right? As soon as the baby's born in call, like once the baby's born, I would then rupture the sac and pull the baby out.
Okay.
If like a piece of it is on their face when they're born, just pull it off, right? So they're not gonna be like suffocated by it if the sac is intact, as long as the placenta is still attached. So I wouldn't like hang out like that for very long. People like to get a picture of it because it's kind of cool looking. But I wouldn't like leave them there. It's like when women have home births and they have water births and babies born underwater. They can survive under there for a little while, but as soon as they touch air, you can't like put it back. They can't like re-mermaid. But once if they're born under there, they can, because they were just in water, right? They can stay like that for a little bit, but as soon as you bring them out, then you can't put them back in there. So I just talked a little bit about neonatal resuscitation. Oh, here's the case study again. Super great. We talked about this. Yeah, these would be bad here. Any presentation besides the head when they're crowning? What else could come out? Feet, butt, arm. That would be a situation where I would be driving as fast as I could to the hospital. If you look, mom's been in labor for a while, you look and you see an umbilical cord, also very bad. What's happening is that umbilical cord's coming through first and that baby's head is compressing against that umbilical cord, and if it's not resolved, it will kill that baby. So, a position to fix that or help that is mom's face down on the cot on hands and knees, but like literally face down, butt in the air, because it pulls that baby back away from that cervix and lets that blood supply with the umbilical cord. But that is a true emergency. When that happens, you will see, if you have paramedics coming, you will see paramedics holding the baby's head off of that umbilical cord, and they stay like that until they get into the operating room. Because if you let that go and that head comes back on that cord, you're cutting off all supply to that baby. So that is something that could happen, but that positioning is important because like I said, gravity's your friend. Use it. Pull that baby back off of that cervix by putting their butt in the air. Meconium a lot of times will cause the color of, so amniotic fluid sometimes has a little bit of like a pale yellow color. So it's anywhere from clear to like a pale, like super pale straw colored yellow. Doesn't have a smell when it's normal. I shouldn't say that. Sometimes it's got like a little bit of a sweet smell. Not that you should sniff it, because that's weird. But you'll have there'll be a smell, and if it smells bad, there's something bad happening. Okay? So if that happens, again, those are situations where you're like, we're not gonna hang out here. We're gonna go to the hospital as fast as we can. If you have feet, that's called breech. Breech babies are born every single day. Hospitals make them a true emergency. They don't like that, but it happens. Women have breech babies with no assistance from OBs all the time. That is not me saying that if somebody walk into somebody's house and there's feet hanging out, that you should hang out there. You should go. But know that that is much less of an emergency than a protruding cord or like an arm. Can't really deliver if an arm's out. That would be.
So what happens if like the arm comes out first? Like, is that one of those times where you just like?
Drive really fast.
Okay.
Because think about what's happening, right? How does a baby have to be
We'll see.
to have an arm? Right?
That's what I thought, but I
Yeah.
was like, I don't know. Part of me just half expected you to say like, push that bad boy. I didn't know.
I try real hard not to put anything back.
First words were stay out of there.
Stay out of there. Stay out of there. There's no reason for you to be in there at any point when there's a baby in there.
Yeah.
Okay?
No testing.
So yes, no touching. Like I said, the only exception to that is that cord prolapse is what that's called. You're gonna call the hospital and be like, help me. And they're gonna be like, here's what you gotta do, friend, good luck. And they'll explain to you what needs to be done. And like I told you, it's literally keeping that baby's head off of that umbilical cord. So that would be the only time that I want you to put your fingers anywhere near that baby as it's coming out.
And would that be like something you'd have to hold there?
Oh yeah,
And then
for a really long
transport?
time. Yep. And if you move your hand, that compression starts again. So then that baby's not getting blood or oxygen. Yep.
Yeah, I'm too confused.
So,
Just catch.
right, just call me.
Hands down.
Just call me and I'll catch, okay?
Got it.
Got it. Put them on oxygen. If you have anything that's abnormal, even if their oxygen saturation is okay, put them on oxygen. And I say that because if they're having a hard time, baby's having a hard time. And giving them oxygen gives baby more oxygen. So if there's abnormal things happening, oxygen is not going to hurt anybody. Oxygen good. So we talked about this. The hardest part is telling mom not to push. She's got to breathe through it. Breathe through it, do not push. If you push, bad things are going to happen because that baby is pushing on that cord. We talked about the knee to chest position, so, face down, butt up in the air. Put them on oxygen.
What would you do for your oxygen administration?
I put them on a non-rebreather at 15.
Oh, okay.
Yeah. Don't try and push that cord back. Try and keep the cord moist. You don't want it to dry out. So, put some saline on a 4x4 and put it up the part that's sticking out. And I've never seen them do it quite like that. I've always seen the butt in the air, but whatever. You're just essentially keeping that baby's head off of that cord. So that is the only time we touch. Breech birth. This is what I'm supposed to tell you. Don't attempt to deliver a breech baby in the field. I wouldn't recommend it. there's gonna be a time, if it ever happens, that a breech birth is imminent and there is not, you don't get a choice. One thing I will tell you about that, there's actually on our YouTube channel, there is a video of a midwife that came and spoke to all of us, and breech birth is something that she's very adamant about that can be done at home. We aren't touching that baby, like we're not, because feet come out, legs come out, butt comes out, they deliver to their head, and then mom has to push really hard to get that head past that cervix. But the more you stimulate that baby by touching them, the more likely they are to try and take a breath while their head's still inside. So, worst case scenario, you get on scene and the baby's already delivered up to the hips, you're not gonna be able to get them out to the ambulance easily. So, if that's the case, the less stimulation to that baby, the better. Does that make sense? Try not to mess with it. There. It looks like they're pulling really hard, so please don't do that. Yep, so essentially supporting of the legs, but not you're not gonna be fumbling around. It's just hold. And she's gonna have to push really hard, because that's the only way that head's gonna come through that cervix. So there's different types of breech. Like butt first, when their legs are way up in the air, is called frank breech. Complete breech is when they're sitting cross-legged, and then incomplete breech would be one leg's hanging out down there. It's very shocking to see, in case you were wondering. Just a little foot down there. If you don't have a choice and mom is delivering that breech baby right there in the house, and she's been pushing for a little while and that head is not coming, they're going to want you to take a gloved hand. So here's case number 2 where you're going to do something up around that baby's head and try and essentially make a space for its head to come out.
How are you reaching that far? No.
Well, there's a baby coming out of there, so it's not that big of it's not like it's this far, right? Think about that.
Yeah, you're right.
Yeah. So, once that cervix dilates, it becomes much shorter of a canal for the baby to come out. Okay. I don't know who that person is and what that maneuver is. So essentially they're trying to get some space for that head to be able to advance. The other thing is upright positioning, gravity, use gravity. So face presentation, these are tough because what's happening is that baby's head is typically really flexed. And if you think about the widest part of your head would be from here to here, right? Not here, because this part will compress. But if they're coming out and you're seeing a chin or a nose or eyebrows, their head is already super flexed, and that's going to be really super hard to push that baby out. It says it's impossible. It's not always impossible. Get the lady to the hospital that need a chest position. So see the hyperflex, baby's head super far back.
Picture the knees and chest position on the cot position.
So, be creative.
Yeah.
Mm-hmm. Are you going to be able to seatbelt somebody in labor? Probably not. Are they going to sit still long enough to have seatbelts on? Probably not. Are you going to try? Absolutely. Absolutely. So if they're, head resting down on the cot and their butt's in the air, could you put a seatbelt across the back?
Yeah.
You got to get a little creative in that situation. If you lift up that sheet and see a face, you scoop that woman up and you go to the hospital. Because there shouldn't be a baby looking at you. There's nothing else for it.
That would be creepy.
It would be so creepy. So this is the limb presentation I was talking about, like that arm, like, hey, like, I don't wanna be anybody waving at me when obviously you cannot deliver a baby that's sideways. They have to be either C-section or they need to be turned. The 1 foot is just a breech presentation. That's much easier than trying to birth a baby sideways.
Are paramedics allowed to like maneuver the baby on the outside, like pushing on the belly in a certain way?
Depends. It depends. There are certain different trainings that we can do that make us more able to do stuff like that, but this would be a medical control thing, like,
Right.
I see an arm, and they'd be like, oh, drive fast, right?
Yeah.
But I'm not going to try and attempt any type of version, which is what that is,
Right.
ever, because that needs to be something that's monitored when it's happening. Okay, shoulder dystocia. So, shoulder dystocia is one of the leading causes of disabilities in babies. So, what that means is that babies' shoulders are much wider than their head. Like they don't have the, because like when they come out, they're all squished, right? But if they're big, the top shoulder can get caught on the pubic bone as it's trying to come out. So that's bad news. We don't really like that. What you'll see is like half of the head is delivered, and as the mom pushes, the head advances, and then when she stops pushing, it retracts. It's called turtling. So essentially, you see this back and forth a couple of times. And she's pushing, like she's giving it, and we're just not really getting much further than this spot. That is bad news. So see how that shoulder's caught on that pubic bone? They see this a lot with the position in the hospital, laying flat on their back. Because like I talked about, you know, the opening of the pelvis is at its smallest when a woman is laying flat on her back with her legs in the air. So the baby typically is also trying to come out sideways, like starting with their face sideways. Instead of face down, rotating, they're starting, so the wider part is getting caught. So McRoberts position. McRoberts position is flat on their back with their legs as far back as they can get them, like literally knees to shoulders, and pushing as hard as they can. If that does not help dislodge that baby, pushing down right above the pelvic bone to try and move that baby's shoulder, and it's quite a bit of pressure. Typically, when you start seeing that turtling sign where that head is not delivering, like it's stuck, you are moving very quickly into these other positions to try and get that baby delivered, because the longer that they are stuck in that position, the more likely that they're going to have some anoxic brain injury or have injuries from that. So you see, like right above that pubic bone, you push down to try and dislodge that shoulder. That can break their collarbone, it can break their humerus, but babies can live with broken arms, right? So McRoberts, pulling those legs back kind of as far as you can. So this is when I was working with that midwife, any even hint of shoulder dystocia, you immediately flip that mom up onto hands and knees, because not only does it increase the outlet of the pelvis, it changes the position of the baby because of gravity, right? You're kind of flipping them and they're floating around in there. A lot of times this will help. Precipitous delivery, which is like the rocket ship baby, right? Labor starts, within 3 hours, baby is here. That's fast. Like that's fast transition for for a mom and for a baby. That usually happens after women have had multiple babies. We see that, I used to see that a lot, like in the Amish and Mennonite communities, because they have 10, 11, 12, 15 babies. So we would miss their births after a certain amount, like they just did it themselves. We talked about the trauma from like the fast delivery to the mom and to the baby. Multiple births. Multiple births at home is a little scarier because there's a lot of times like one baby could be head down, but the other one's going to be breech because they don't listen very well in there. Sometimes people don't know that they have two babies in there. If you deliver a baby at home and 10 minutes later, and like the center's delivered and all that, 10 minutes later they start having contractions again, that's a pretty good sign that there's another baby coming. Like it wasn't stressful enough with one, now you're gonna have two, right? If mom is term or close to term and it's a small baby, like you're like, wow, this is a really little guy, there's a chance there's another one. So be aware of that. We talked about meconium. So if they breathe that in and it gets into their lungs, they can get what's called meconium aspirated pneumonia. Then they go to the NICU. Usually they get intubated for a little while. It can cause fetal distress while in labor. So if you have meconium present and the baby's vigorous or they're crying appropriately, do not suction.
That'll warn you.
Right? They were distracting me. So if baby's crying, they cleared the crap out of their lungs. They don't need you to aggressively suction them. If they are not doing that, if they're flail and they're gray and they're just not looking good and there was meconium, you're going to suction the nose and mouth. You're going to check their heart rate. If their heart rate's less than 100, you're going to begin chest compressions. Also, while providing positive pressure ventilation. Oh, preterm labor. So preterm labor is anything that occurs between the 20th and 37th week. Cocaine and other drugs are known to induce labor preterm. Try not to allow mom to push that baby out. You know, they keep saying that, and you can try that. But if mom's feeling like she needs to push, there's not a whole lot that her body can do to stop that. It's not like a choice. You're not like, I just really would like to push. It's like here we are, no choice. We're gonna have a baby. I will say that the preterm babies that I've been involved with in EMS that were born super early typically were to drug-addicted moms. Like pre-hospital, not the ones in the hospital, that happens, but the ones I've seen personally didn't know they were pregnant or didn't care they were pregnant or whatever the situation is, and they're delivering a 21-week baby on your ambulance cot. So there's always a chance of that. You know, they didn't even know they were pregnant in the first place. But there are many, many other reasons for women to go into preterm labor. But those typically happen, you know, they get to the hospital and it's hospital handled. The stuff that we see pre-hospital is more, in my experience, has been more like, didn't know I was pregnant, or drug use, or things along that nature. And those babies typically are not able to be resuscitated because they're too little. Place the mom on oxygen. So preterm, less than 5 pounds or born before 37 weeks, they do typically get cold easier. So keep them warm, put them on mom, warm towels, you know, warm blankets, however, if you like, lay a blanket and then put a hot pack, anything to keep them warm. Interesting fact from a NICU friend of mine, baby boys born before 37 weeks typically end up in the NICU at a much higher rate than girls. They call them wimpy white boys in the NICU because they just don't acclimate well to the outside world before 37 weeks. So the NICU is typically full of little Caucasian boys.
Would you consider 37 weeks full term then? Because I know you said 38.
I do not consider 37 weeks full term. That's early term. Typically induction occurs at 37 weeks if there's something going on. That's not usually a typical scheduled induction or a choice.
Or if there's more than one. I know twins.
Yep, twins sometimes they deliver, and 37 weeks, so the hardest part is like the respiratory system isn't developed well enough yet at 37 weeks. You go into labor because the baby is like, oh, like they have like a turkey cooker, like, I'm done, and then you go into labor. Before that, if you force that baby to come out, there's a lot of times that they have a little trouble breathing, they have a little trouble acclimating to the outside world, and the little boys typically end up in the NICU even just for a day, because for some reason, they just don't do well. They just don't like it, they're mad, they're out, I don't know. They're like little Karens in there at 37 weeks. See, plastic bags, told you. Right. Gentle suctioning if needed, but typically you don't. For these ones, you might have to help them because they're not developed enough to do it on their own. Contamination, I'm not sure what you're contaminating them with, but, okay, so I'm assuming what they're saying with that is like bleeding from the umbilical cord, like you clamp and cut the cord, and the clamp's not working super well, they can bleed from that. So make sure that you have it clamped well, because they don't, at 37 weeks, they have less blood volume than they do at 40 weeks. I'm not sure, again, what we're contaminating them with. There's a baby, full term, healthy looking. I think he's adorable.
Settle down, you Grinch.
That is a preacher baby. Look at it, it's a white baby boy.
Probably in the NICU.
Shocker. Yep, definitely in the NICU. So, they just don't do as well. So if you ever get a chance to talk to a NICU nurse, ask them, how many of the babies in the NICU are boys? I'm not lying. So, preterm babies typically require more support. They're going to require IV access, they're going to require intubation or CPAP, not our CPAP that we can do, baby CPAP. They just don't do quite as well. I struggle with this one a little bit. So 42 weeks is what is considered late term. Now, yes and no. Women can go to 42 weeks without any complication at all and go into labor on their own, and baby comes out at 7 pounds. Because like I said at the beginning of this, due dates are an estimate. They can't tell you exactly when that baby's gonna come. Sometimes your baby's born on their due date, which is crazy. Sometimes they're born 2 weeks before and they're 8 pounds. Sometimes they're born 2 weeks after and they're 6 pounds. It's all about when baby's done cooking, right? Right, or that. The concern is if you're past dates and you can have breakdown of the placenta. So the placenta will start to calcify and then it's not doing a great job taking care of that baby. So that is where the concern is. At 42 weeks, typically at 41 weeks, they'll start doing like monitoring weekly. Like every couple of days they'll come in and you'll do a non-stress test where they just hook you up to a contraction monitor and a baby heart rate thing, and you have to sit there for an hour and make sure baby looks okay. And they make sure everything else looks okay. Because the placenta starts to break down, it can cause hypoxia for that baby. I've seen people go further than 42 weeks and have a perfectly normal baby, and I've seen women who stay there 40 weeks and have a baby, and the placentas have calcified. So due dates they're an estimate. Whoa, I don't know what that just said, but we're gonna skip it, I guess. postpartum, so we talked about a blood loss of greater than 500 mLs after delivery is considered a postpartum hemorrhage. So we talked about how the uterus is kind of boggy, it just kind of like isn't doing what it's supposed to be doing. So it's supposed to be like contracting, delivers the placenta, and then it kind of gets firm, and it's supposed to stay that way. If it doesn't do that, we are supposed to do what's called a fundal massage. Now, this is not a fun time for the person having the baby or just had the baby. It hurts. What you're doing is you're firm pressure to press on that belly, because typically what's happening if you have a boggy uterus is there's blood clots that are stuck in there, so it can't contract down to what it's supposed to be doing. So as you push on that, don't be surprised if blood and blood clots come out. That actually would be good, because then that uterus will be like, oh, I'm supposed to be doing something. Another thing that you can do is have that baby latch, like to nurse on mom, to breastfeed, because that will cause uterine contractions as well. So, two things. I would latch baby first. Typically after baby's born and dried off a little, mom will latch baby pretty quickly after they're born, and that helps with that boggy uterus. Put them on oxygen because it's blood loss and we treat them for shock. Ooh, okay. An embolism. So you can get a pulmonary embolism, you can get an AFE, which is an amniotic fluid embolism. Those pretty regularly are fatal to the mom. So what happens is amniotic fluid gets into the venous system and creates a clot of that amniotic fluid. So typically, like, they'll go from being totally okay to a sudden onset of shortness of breath. They get tachycardic, they get pain in their chest, they get hypotensive, they look really shitty, and they sometimes will lose consciousness. And then they go into cardiac arrest. So this is not something to mess around with. A lot of moms die from this. It's not super prevalent. It's pretty rare, but you start reading about something and then you read about more and more cases. So, right. If you have that chance, if they still have a heartbeat, you're going to give them oxygen and transport them. Otherwise, CPR. We talked about how babies lose body heat quickly, so the baby needs to be dry. Wrap them in a blanket or put them in a plastic bag. Suction if you need to, if they're not clearing the stuff on their own. So sniffing position, I'm sure Jason's talked about that. So babies have, if you look at the size of their pinky, that's about the size of their airway, which is it's pretty little. So if they're like this, you think they're breathing super well with their head to their chest? No. So if they're like this, though, do you think they're breathing super well?
Probably.
Probably not, because you're going the opposite, right? So like this little straw, if they're crimped forward, no good. If it's flipped backwards, you're going to crimp it off in the opposite direction. So a sniffing position is like literally like just a little bit of a head extension, just like if they were trying to sniff something, right? That's what sniffing position is. And that creates optimal airway openness. So APGAR. APGAR, you're going to do one at 1 minute and one at 5 minutes. So these are that's your mnemonic. Appearance, pulse, grimace, activity, respiration. So how does the baby look, right? Are they gray? Are they pink? Are they, do they look bad? Right? Your score is 0, 1, or 2. 2 obviously is the best. How's their heart rate? If their heart rate's above 100, give them a 2. If their heart rate's 60, you should be doing CPR. Grimace. So are they, babies look pissed off when they come out, right? They've like that scowly face and they're just crabby looking. That's a good thing. That's an appropriate response. Activity. Are they kicking their arms and legs and moving around, or are they just laying there like this? And their respiratory rate. So you do one at 1 minute and one at 5 minutes, and it should improve. You want me to keep that up, or are you still writing? Okay.
Can you go over the scale one more time? Zero's bad.
Zero's bad. So anything like a 7 or above is pretty typical for your, a 6 or above is pretty typical for your 1 minute, but after that it should be 8, 9, 10. This should be in your book too, just so you know. We good? Okay. Like I just keep talking about in front of these slides here. 7 to 10 is normal. 4 to 6, you should be doing a little something, trying to help them out a little stimulation, maybe a couple of breaths. 0 to 3 means you have a flaccid gray baby with no breathing, not doing anything that it's supposed to be doing. So then you would be doing PPV, possibly CPR. Typically, stimulation just by using a towel and rubbing their back and like cleaning them off is typically enough to stimulate them to do what they're supposed to be doing. If you're transporting that baby, you should be like reassessing along with mom. A lot of places say that we're not supposed to transport mom and baby in the same ambulance because it's 2 patients. If you don't have another ambulance available, you do what you can. Hopefully you have 2 people back there with you. Oh God, see, I can't read that. That's probably in your book. We talked about all this. Most newborns don't require any intervention from you at all. You put them on mom, they figure their shit out, they start breathing, they start crying, everything's good. A couple of them will come out and require you to help them breathe a little. Help expand those lungs out, and then a very few will require anything beyond that. Again, it takes a long time for their pulse ox to come up to where you think it's supposed to be. So if the first thing you do is put a pulse ox on this baby, you're going to be a little scared because it's going to be low. So the only time I've ever put a pulse ox on a baby was at a 24-hour check, because you check for congenital heart conditions by putting it on one side and comparing it to the other. I've never, like post-birth, put a pulse ox on a baby in a home delivery. So, but if they're struggling, that's a different situation. There. So you're going to want to put it on their right hand, if you need to do it, because the ductus arteriosus of the aorta is still trying to flip and close and do what it's supposed to be doing so that the baby can circulate its own blood. But those numbers aren't great. If you were to look at those for an adult, you'd be like, crap. But, 10 minutes after that baby's born, I wouldn't expect their sats to be above 90. And that's normal. Always remember that you're looking at what your patient looks like, not only what you're looking at on these cool tools we give you. Oh, we already talked about this. I'm not going to be flicking anybody's feet, but if you'd like to use that as your stimulation, you go right ahead. Usually rubbing their back with a warm towel, either while they're on their side or on their belly, because if they have crap in their airway, you're not going to let it go back. They kind of will expel it out that way. So we've talked about this, if the baby looks crappy, there's a good chance that you're going to have to do something. Warm, position the airway, suction if you needed, stimulate, inverted pyramid for landing or resuscitation. So, unlike adults, when you have a baby that's born and they don't look super great, or you don't feel a super great pulse, the first thing that you should be doing is PPV, so you should be breathing for them. Because a lot of times, a couple of good breaths or a minute of breathing for them will bring their heart rate back up. So, as you can see here, dry warm position, suction and stimuli, oxygen, BVM, and then chest compressions, and then, you know, beyond that, we would intubate them and give them meds for advanced life support. Yeah, we talked about this. So for neonatal resuscitation, it's the rate that you're going to be providing ventilations is way faster. So it's breathe in 2 and 3 and breathe. It's 3 seconds in between. So breathe in 1 and 2 and 3 and breathe in 1 and 2 and 3 and breathe in 1 and 2 and 3 and breathe. It's fast. It's a fast rate. You do that every 30 seconds. You reassess. Is the baby starting to breathe on their own? Is their heart rate getting higher? You're going to keep doing that. If the heart rate drops below 60, you're going to do chest compressions while you're ventilating. Typically that means that there's something else going on beyond them not breathing well.
What's the best place to look for the pulse? I forget.
Typically I'll listen with a stethoscope, but they're brachial.
Oh, that's right, yeah.
It's much easier to hear with a stethoscope than trying to fumble around and find. Yeah, I can't say I've ever done that, but you know. Okay.
Are you putting the stethoscope there?
No, right on their chest, right over their heart. That's probably in your book too, I would assume. That's really hard to read. Yeah. All of these, here we are, back to the case study. So that means we're almost done. How about that? We learned about all this stuff. 3 stages of normal labor. There's a lot of changes that happen in the woman's body. Typically, anything abnormal presenting, you would try not to deliver them outside of the hospital. The biggest take home, women have babies every day, all across the world, all by themselves, in the middle of a field, at their home, in the hospital. And 9 times out of 10, everything is totally fine. The times that we're getting called, something is usually going wrong or abnormal. So that is why they stress the abnormals to us, okay? That's why it makes this childbirth seem a little scary. Up here, if it's a scheduled home birth and something's going wrong, the midwife is going to ride with you, okay? They're not gonna just be like, peace out, good luck, right? Even if like something's going on with baby, she's going to come with you. She's not going to just leave you.
If somebody's having a home birth, could they like warn EMS that that's going on, so if they get a call or not really?
No. Technically, that would be a HIPAA violation because we're not involved in their care.
Right.
The midwife that works up here will typically tell me if she's got people up. She doesn't give me any names, but she'll be like, I have women in the area up there that are close to due dates. Like, super great, I'll pay attention. And there's been times where she's called me because I worked with her to go check and labor sit till she can get there. So, if she's calling, something's going wrong, but she's not going to just leave you. She's going to come with you. She's going to help you manage whatever it is. You're not going to be by yourself. Try not to be scared of women having babies because they do it all the time. Is the
So as
bottom line.
first responders, we're just, you go find out what's going on, comfort.
Yeah, supportive care, exactly. And if you have to do anything to resuscitate, so you're gonna wanna bring your stuff in, right? Like, you're not just gonna walk in and be like, hey, how's it going? How you doing? Right? But if you walk in panicked, how do you think mom's gonna feel? She's already freaked out, right? Especially if she wasn't planning to have a baby at home. She's like, get me the hell out of here. And you're like, yeah, probably not. So I don't expect you to be like calm on the inside, but a calm presentation on the outside will help. Like I tell all the people around here, call me. I'll come. If I'm home, I'll come. I've helped deliver a lot of babies and had enough of my own babies, so I'd be happy to be there. Now we're going to play with this mannequin, and I'm going to show you the OB kits that we currently carry. But you can take a break.